Well, good morning, all. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll go ahead and get started with a few logistics and then introductions for today. Please be sure to join us for next week's Grand Rounds. The talk will be on corporatization of medicine, given by Dr. Jane Ju from OHSU. As many of you know, Grand Rounds is a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are always here on the Teams live platform as we are today. Often we meet in person at Providence St. Vincent on Tuesdays at 8 a.m. and sometimes in person at noon, also on Tuesdays at Providence Portland. You can look at the weekly Grand Round invite to always know when and where we'll be meeting. And you can earn CME credit by being live in the room, watching live virtual, or by watching a recording of the event. And again, the recording is also available at the weekly invite. I'm delighted to be joined today by Dr. Michael Lyoun, a practicing cardiologist with Providence Heart Institute. Dr. Lyoun grew up in Portland, Oregon, and completed his medical school here at OHSU, and then went on to do internal medicine residency at UCLA. He returned to Portland to complete a fellowship in cardiovascular medicine at OHSU and currently serves as the director of the Jack Loacker Center for Cardio-Oncology. His clinical and research interests include the use of cardiovascular imaging in oncology populations and evaluation of cardiotoxic potentials related to various cancer treatments. Dr. Lyoun, we're so delighted to have you with us today. Thank you.
Thank you so much for that incredibly kind introduction. And thank you for giving me the opportunity to present virtually today. The title of my talk is Advanced Cardiac Imaging for the Internist. There's no financial disclosures. So let's kind of go through our learning objectives for our talk today. So first, we're going to kind of focus on acquisition protocols of different types of cardiovascular imaging modalities. Then we're going to discuss indications and go through guidelines for when cardiac CT imaging or nuclear stress imaging may be warranted. And lastly, we'll review various disease patterns that we oftentimes look for with cardiac MRI. Let's start with a little background. So the title of the talk is Advanced Cardiac Imaging, and this is kind of a, I'd say, ill-defined term that is thrown around a lot in the realm of cardiology. They now even have advanced cardiovascular imaging fellowships that some individuals can do after their general cardiology fellowship. But as I kind of said, it's ill-defined, it seems a little nebulous. And kind of what do we mean in this topic? Well, I think for our talk today, we wanted to specifically focus on cardiac CT, cardiac MRI, and nuclear imaging, specifically with a focus on PET cardiac imaging. The whole idea of these different imaging modalities is really a way to non-invasively evaluate cardiovascular anatomy or function with kind of reducing the need for invasive testing. So trying to cut down on coronary angiograms, right heart cath, myocardial biopsies, what have you. The reason we haven't seen some of this testing take off as much as we would have liked is maybe a subject for a different talk, but I think financial headwinds that we've kind of dealt with, as well as insurance reimbursements, have limited the widespread use of these thus far. Okay, well, let's start with some fun background trivia. Maybe some of you know this, but I wanted to start talking about cardiac CT first. And to talk about that, one of the things I remember learning many years ago was, what does the famous band, the Beatles, and cardiac CT have in common? Well, there was a, well, now defunct British company, EMI, Electrical and Musical Industries, that financially back in the 1960s was not doing well. However, with their musical arm, they had recently acquired Capitol Records, which had signed an up-and-coming band from Liverpool, England, named the Beatles. They were about to let go of one of their more storied electrical engineers, Godfrey Hounsfield, However, with the signing of the Beatles, they had huge profit margins, were able to shift some of those profits towards some of their engineers' kind of research endeavors. And Sir Hounsfield was very interested in creating an X-ray that could penetrate the skull. And so they essentially set aside time and funding for him just to tinker around with that. And in 1967, Sir Hounsfield created the first CT scanner, which coincidentally was the same year that the Beatles released their Sgt. Pepper's album. And I think we all know Hounsfield now, as he's been immortalized with the pixelated radio density measurement that we use in CT imaging, the Hounsfield unit. Here's some of his sketches. Okay, so let's talk about cardiac CT. So, what are we really referring to when we talk about cardiac CT? Well, besides just doing a CT scan where the heart is in the field that you're looking at, the main challenge with imaging the heart is that it's not a static organ. So if you're doing a CT scan, say abdomen, pelvis, the liver, the kidneys, what have you, those are relatively static, but the heart is obviously beating in the chest. And if you just scan the heart as is, there's going to be quite a lot of motion artifact as the heart is moving back and forth. And so the whole idea of cardiac CT is you want to try to capture the heart with minimal to little imaging artifact. And so with cardiac CT, we rely on this concept called ECG gating or EKG gating. What we do is we attach an EKG lead to the patient when we scan them. And the idea is we follow the cardiac cycle and we try to scan, have the patient go through the scanner, have the imaging done during the most standstill point of the cardiac cycle, diastasis, as we call it. And when you're looking at an EKG, and you look at QRS to QRS, we say that maybe somewhere around, now this kind of varies for everyone, but maybe somewhere around 70% or so of what we call the RR cycle, or the QRS to QRS cycle, is that period of time where you have the most standstill, and hence the lowest chance of having motion artifact. And through this, you're really able to improve spatial and temporal resolution. What I'm referring to for the most part is what we call prospective imaging. And I think historically people have used the term step and shoot. And the idea being, I'll show you here, that with prospective imaging, you scan, this is kind of an example of that around 70% or so our cycle, you scan the patient during these time periods. Now you can also do what's called retrospective imaging, where you scan them through several cardiac cycles and they're being scanned the entire time. Now, of course, the main issue with that is there's a lot more radiation exposure. And so the whole idea of ECG gating is not only are you dealing with limited motion artifact, but you're also really significantly reducing radiation exposure to the patient. We'll come back to retrospective imaging a little bit later, but it does have uses sometimes for patients who have arrhythmias, or if we're actually doing functional assessments of the heart. So some technical aspects of cardiac CT. When we do a cardiac CT, we're typically giving somewhere between 80 to 100 cc's of contrast. Now, we compare this to, say, an invasive coronary angiogram, which diagnostically, depending on the circumstance, can be up to 50 cc's. Of course, that's intra-arterial contrast, where this is intravenous. We try to have the patient hold their breath, shifting the diaphragm down, again, trying to limit that artifact. And we oftentimes have patients take beta blockers, both the day before and the day of the scan. Again, lowering heart rate, increasing the time of diastasis or diastole, and hence reducing that motion artifact. And as I alluded to earlier, actually the radiation exposure with prospective imaging is decently low. If we compare our average annual ionizing radiation that we all kind of experience just from living, which is a little over 3.5 millisieverts a year, we can see that maybe that's not that much more. And you're left with these really beautiful images that can be quite helpful to show a patient in clinic. We have the 3D rendering on the left, patients really like to see, and then the two-dimensional imaging on the right, which is oftentimes the imaging that we're kind of scrolling through ourselves as we interpret these scans. Okay, well, where do we use cardiac CT? Well, as I kind of alluded to a moment ago, you can actually do functional assessments with cardiac CT. You can get a left ventricular ejection fraction through retrospective imaging. We mostly know it through its uses of evaluating the coronary arteries and the coronary anatomy. Coronary calcium score is obviously an incredibly popular use of it. And I'll say coronary calcium score is such a detailed topic. Maybe at another time I can come back and we can do a whole nother grand rounds on that. But I'd say that we won't really spend too much time on coronary calcium score in this talk today. And then, as I was kind of saying with left ventricular ejection fraction, you can also do valvular assessments with cardiac CT. We also will do surgical or percutaneous planning with cardiac CT as we make measurements to understand maybe what size valve a patient may need if they're being evaluated, say, for aortic valve replacement. A very common one, maybe we're starting to come across more and more, especially in the inpatient realm, is using cardiac CT to rule out clot or thrombus in the heart for those individuals with atrial fibrillation or AFib prior to receiving a cardioversion. In fact, here's an example of a patient I cared for a couple weeks ago who did have a filling defect in their left atrial appendage consistent with clot, and hence their cardioversion was postponed until the clot had resolved. And we now know that actually cardiac CT is a very viable alternative to transesophageal echocardiography in these circumstances. Okay, now I'm going to get into some of the technical minutia. If people don't mind, I apologize. Some of this stuff I find to be quite fascinating. So let's talk specifically about coronary CTA. Okay, so this is looking at the coronary arteries, and we're looking inside the coronary arteries. We're looking at the lumens. Now, the challenge with looking at a coronary artery with a regular CT scan is coronary arteries are very, very small. I mean, we're talking somewhere in the range of what we're looking at between 2 to 4 millimeters in diameter. So you need very precise spatial resolution. And because of that, we try to create a slice thickness as we scan the patient of roughly around 0.5 millimeter. Now, every slice you have of a patient is dependent on the row of detectors that you have for your CT scanner. For the most part, we think of CT scanners as a, say, 64 slice scanner. Well, if you're doing 0.5 millimeter slice thickness, you're going to cover about 3.2 centimeters of the heart. And if we think about the heart on the cranial to caudal axis and kind of the y-axis, as I think of it, the heart is maybe up to 14 centimeters or so in length. So this is why you want a CT scanner with a lot of rows of detectors. We typically say, maybe having a 256 slice scanner, there's 310, what have you, can be quite helpful because you're able to cover the entire heart in 1 to 2 scans. And not only are you reducing radiation exposure by doing that, but you also are able to eliminate the dreaded what we call stitch artifact. And here's an example. This is the right coronary artery. And what we're seeing is this person was probably being scanned in a 64 slice scanner. And because of that, they had to scan them several times and then reconstruct the image. And you can see here that it becomes very difficult to interpret what's actually going on in the right coronary artery lumen. So when we think about the predictability for evaluating obstructive coronary disease with coronary CTA, it's quite impressive actually. Has a very good negative predictive value. So if you're getting a coronary CTA on an individual and you see there's no calcified plaque, there's no obstructive coronary disease, well, the negative predictive value can be up to 99% depending on what study you look at. But the challenge, I think, historically that we've had with coronary CTA is the positive predictive value, which is oftentimes compromised by its specificity. And what am I getting to here? Well, one of our other kind of dreaded complications of the scan itself, of the protocol itself, is dealing with this idea of the calcium blooming artifact, which we may have all seen as we scrolled through CT imaging of our patients. Essentially, if you have an individual who has very dense calcified plaque in their coronary arteries, it creates this blooming artifact such that it becomes incredibly challenging to look within the lumen of the coronary artery, hence limits our interpretation. So when we think about the limitations of CT, one of the main things that I always think about whenever I'm ordering this for a patient or someone's asking about doing it is this someone who, say, has known coronary artery disease? Do they have a history of a very high coronary calcium score scan in the past? Are they older? Do they have longstanding poorly controlled diabetes, maybe advanced chronic kidney disease? These are all circumstances where you're going to see kind of chronic calcium mishandling and hence a lot of calcified plaque buildup in the coronary arteries. Now, of course, I put stenting on here. The Society of Cardiac CT does say that these imaging, that coronary CTA can be used so long as the prior stent that was placed is at least 3 millimeters in diameter. But I will say that for the most part, I feel like coronary CTA is an excellent imaging modality for those individuals with stable chest pain and no known coronary artery disease or no known extensive calcific coronary disease. So the cheat I'll sometimes always do is before I order a test, this test for an individual, I'll click on the imaging tab and I'll see if they've ever had a chest CT before for any other reason. And I'll scroll through it quickly and say, do they already have atherosclerosis in the coronary arteries? Is there calcific coronary disease in there? And if I see really dense calcifications, then I say this might not be the best test for them. So this is the kind of imaging we're left with. This is kind of an isolated view of the left anterior descending coronary artery wrapping across the left ventricle. And as you can see here, it's incredibly helpful because not only does it give us an anatomic evaluation, but we can look both for plaque and obstruction from plaque. And this was a patient I saw, gosh, 4 years ago now, a 44-year-old gentleman who had presented with chest pain and a vague syncopal history in the past. He had some concerning features, and we decided to do a coronary CTA as the first test. And what we're seeing here is subtle but incredibly concerning. So what I have the arrow to is the left anterior descending artery. But what's happening here is the left anterior descending artery is actually coming off where the right coronary artery should. This is what we call an anomalous coronary artery. But this is the malignant path that we all worry about. What am I talking about? Well, let me kind of show you here in a different image. You can see the left anterior descending kind of coming off from this anomalous course, but it courses between the aorta and the right ventricular outflow tract. And there is a theoretical and very concerning risk of temporary, basically, impingement of the left anterior descending and risk for sudden cardiac death. And so this patient was sent to CT surgery for ligation and reimplantation of his left anterior descending artery. Here's another relatively young patient that I had seen in clinic who, curiously enough, had actually had a coronary calcium score just a couple years prior of 0, but was having some stuttering chest discomfort symptoms. And we sent him for coronary CTA. And what we saw here was a pinch point of non-calcific plaque in the proximal left anterior descending artery, which actually ended up correlating quite nicely with the coronary angiogram he ultimately ended up having. Now, the curious thing here was in the cath lab, we had actually done hemodynamic testing. I think we all know now that with both CT imaging as well as invasive coronary angiography, we don't just estimate the caliber of stenosis, but we actually do a hemodynamic fluid study of blood flow going across the stenosis to understand how severe it may truly be. We call that testing flow reserve, and you're looking at this flow kind of in a stressed state. So we call this fractional flow reserve. And I want to talk about that a little bit. So this is something that we use to kind of understand these borderline, visually borderline, excuse me, stenotic lesions. What you do is you have to have the understanding of knowing that with plaque in a select area, there's going to be a pressure drop just distal to that obstruction. So you compare the distal pressures compared to proximal pressures. Oftentimes in the cath lab, we'll use the aorta. That ratio, if it is significantly impaired, implies that this is a hemodynamically significant stenosis. But now we have computational fluid dynamic software that can model this, and we can actually obtain fractional flow reserve hemodynamics with a coronary CTA. Now, this is proprietary software. There are a couple companies. HeartFlow, I think, was one of the first ones to make it commercially available. And we don't, I think, totally understand all the physics behind it. But this is a study that is done quite often when we send our patients for coronary CTA who may have these visually borderline stenoses. We consider an FFR CT less than 0.8 to be positive, and oftentimes that may be a threshold for not only getting them on medications to help with anginal symptoms, but potentially also sending them to the cath lab as well for invasive coronary angiography and possible stenting. Let's compare coronary CTA and its gold standard coronary angiography. So the radiation exposure, this is now, by the way, this is diagnostic coronary angiography, not if we're going to intervene. But the radiation exposure is pretty comparable. Of course, the contrast volumes are different, like we said earlier. Mind you, one's intravenous and one's intraarterial. The spatial resolution is much better with diagnostic invasive coronary angiography, but it is improving with coronary CTA, as well as the temporal resolution, being able to see where things are in space and time. And that's because of kind of a relatively newer technology that we call dual source CT imaging. Typically, when you think of a CT scanner, there's one X-ray tube and one detector. But with dual source, you actually have two X-ray tubes and two detectors that are actually mounted at 90-degree angles. One of the main issues with coronary CTA is the coronary artery that has the most motion artifact as the right coronary artery. It's moving around the most. And so if you have a dual source scanner, the the X-ray tube, instead of having to rotate 180 degrees, only has to rotate 90 degrees to capture the entire heart. So you can capture the entire heart about twice as fast or in half the time, and hence much improved temporal resolution. We talked about how we can assess hemodynamics, but of course the calcification artifacts are really going to limit our ability to get diagnostic information for potentially hemodynamic stenosis in coronary CTA. So kind of with this growth of coronary CTA, there's been a plethora of studies that have been published over the last 2 decades. I'd say probably one of the more famous and maybe even till now slightly controversial studies was the Scott Hart study, initially published in the New England Journal of Medicine back in 2018. And this was a study that actually compared standard care for stable chest pain for sending an individual for coronary CTA. They looked at basically their endpoints were myocardial infarction, death from cardiovascular disease. And what they actually showed, and this is kind of where the controversy is that actually sending patients for coronary CTA resulted in a significantly lower rate of myocardial infarction or death from heart disease. And I think part of the speculation is that with a coronary CTA, you can show the patient their imaging. They can see the atherosclerotic plaque. So not only can you motivate a patient to make lifestyle changes, these are individuals you can be starting on cholesterol-lowering therapies, statins, baby aspirin, what have you. In fact, actually, just last year, the 10-year outcomes from the Scott Hart trial were published. And while the results were still positive, they were a little bit more modest, but still statistically significant. Another study, this one maybe isn't talked about as much, but I kind of found it interesting. It kind of came maybe a year or so after the famous ischemia trial, which we all know was a study looking at intervention for obstructive coronary disease in stable chest pain patients. This was the discharge study published in 2022 in the New England Journal of Medicine. And for those patients with stable chest pain who had been referred for coronary angiography, they took a group of those patients and at first actually obtained a coronary CTA. And then they looked at major adverse cardiovascular events 4 years out, and it showed that there was really no difference between the two groups. And so what we've kind of seen is for those individuals who have coronary CTA, so long as say like proximal LAD or a left main stenosis, something really concerning is not detected, oftentimes you can maybe defer invasive coronary angiography for patients maybe with more downstream stenoses, so long as you can control their symptoms with medications alone. And based on these studies and many studies that came before it, the 2021 AHA-ACC chest pain guidelines have actually given a class 1A recommendation for the use of coronary CTA in those patients who have at least intermediate risk and are presenting with stable chest pain. What is intermediate risk? This is always this may be again, a whole nother topic of discussion, but I'd say for the most part in the realm of internal medicine, most of our patients are intermediate risk. We typically think of those patients who are at least, maybe middle age with at least one or two coronary or cardiovascular risk factors. Okay, let's just talk about a couple other fun novelties that we'll use cardiac CT for. Well, as I said, if you do retrospective imaging, you can actually evaluate both ventricular function and valvular function as well. This was a patient we took care of about a month ago. In fact, if any of the residents at PPMC are tuning in, they may remember this scenario. This was a 63-year-old gentleman with a prior history of a mechanical aortic and mitral valve replacement. He was coming in with worsening shortness of breath and concerning heart failure symptoms, and we had done echocardiography. We saw that the hemodynamics of his mitral valve were normal, but he had very high velocities across his aortic valve. The challenge was we couldn't really see what was going on with the aortic valve because it was a mechanical valve and you really just can't see into it that well. And because of that, we ultimately ended up getting one of these 4D CTs. Now, this is an en-face view. We're looking right at the mitral valve, and we can see it's a bileaflet mechanical valve. It's opening appropriately. But now, let's look at the mechanical aortic valve. Now, this is a long axis view of that aortic valve, and it's subtle, but what we can see is that the anterior excursion of these leaflets are somewhat compromised, especially the anterior, or maybe on your screen here, the upper leaflet not moving up as much. And ultimately, this gentleman was sent for reduced sternotomy. And I discussed with a surgeon when they explanted his mechanical aortic valve, he had a very large pannus growth across his mechanical aortic valve. A pannus is basically this inflammatory vascular tissue that we sometimes see grow into prosthetic valves, and ended up having a bioprosthetic valve put in place. Unfortunately, I don't have any pictures. They threw away the valve before they took any pictures, but I guess you'll just have to take my word for it. As I said earlier, cardiac CT can also be very helpful in the structural heart realm, especially with valvular planning, both for percutaneous aortic valve replacement and mitral valve interventions as well. We get CT imaging not just to measure the valve circumference and understand what kind of valve we should put in its place, but we also like to look at vascular access, say looking at the caliber and maybe I'd say plaque buildup of the femoral arteries, iliac arteries, and descending aorta. And you can kind of get an idea here of what we do in our structural heart planning. Kind of a, I'd say very unique scenario, but when I was on our structural team, this was something we would always kind of plan out. So let's say you have an individual with a bioprosthetic mitral valve, and that valve is no longer working well. And they're going to be sent for a percutaneous mitral valve replacement. We call this valve and valve or mitral valve and valve. The challenge here when we do it, the thing we all kind of dread, is that the anterior leaflet of the bioprosthetic mitral valve may become fixed and obstruct into the left ventricular outflow tract, such that you're going to have what we call a left ventricular outflow tract obstruction, kind of almost mimicking hypertrophic obstructive cardiomyopathy in some ways. So we really don't want that. And the nice thing with cardiac CT is we can kind of plan this out and kind of see where those leaflets are going to end up being before we even do it. One of my own kind of research, and this is something we published, I guess, a couple of years ago now, is the use of all these different imaging protocols with cardiac CT in an oncology population. I mean, these are patients who may have hematologic derangements, and maybe, direct intervention may be somewhat limited due to, say, thrombocytopenia or something. And so we can get a ton of non-invasive understanding of their vasculature without direct intervention. Okay, that was about half an hour on CT. We still have two other topics, so I might speed it up a little bit. We're going to totally shift topics and talk a little bit about nuclear cardiology. So everything we were just talking about with CT is you actually have an X-ray tube that's emitting the X-rays, but with nuclear cardiology, it's actually the exact opposite. You are injecting a radioisotope into an individual. That radioisotope is actually radio labeled to a cardioselective protein. This protein wants to go to the myocardium. And once it gets to the myocardium, it then emits a photon, a gamma photon, as it moves from a metastable to a stable state. Kind of historically, and for the most part, what I'm talking about is technetium. That's the most commonly used one. So the person is actually emitting the imaging, the gamma photons. And then you actually have basically these scintillating crystals, this camera that rotates around the individual and recreates an image of the heart based on where it picks up these gamma photons. This kind of explains it here a little bit. So what I'm kind of referring to is what we, for the most part, use is SPECT, single photon, because again, like I said, for the most part, we use technetium, single photon, which the technetium going from metastable to stable state emits a single gamma photon. Emission, because the person is actually emitting it, right? X-rays are not coming into the body, they're emitting it. Computed tomography, that is the three-dimensional imaging that is being created as the cameras move around the person. Now, let's compare that to PET. In PET, we're using positrons, antimatter particles, to create the image. And the thing that's so nice about PET compared to SPECT is that, unlike SPECT, with PET, you actually have two different photons that are being produced as the positron decays. You have two different high energy photons that are emitted at 180-degree directions. What that means is you basically get a lot more information. The camera is able to pick up a lot more information, a lot more gamma photons, and this subsequently leads to improved spatial resolution. And we'll kind of get to some of the other things in a moment, that the information we can get with it. I think PET is such a fascinating topic. In the realm of cardiology, there are a couple different tracers that we think of that we can use. Probably one of the most commonly used one for PET stress imaging. So, we were talking about SPECT stress imaging. So PET stress imaging is rubidium-82. Now, this oftentimes is produced by a generator that you have in your nuclear lab. The really nice ones that create really, really crisp pictures, O15 water and N13 ammonia. These, unfortunately, have to be produced by an on-site cyclotron. Cyclotron is basically like a particle accelerator that makes these positrons. And so you can understand that, something like this would be reserved for like a large major academic center only that perhaps has the funding and research capabilities to support a cyclotron. And then the other one that recently gained FDA approval and we've been very excited for, although I don't know how much it's really taken off yet, is F18, what we call fluoropyridaz. This one's really exciting because it's stable enough that you don't need an on-site, you don't need a generator, you don't need an on-site cyclotron. And it has a slightly longer half-life too. And we'll get into that in a moment. I think we all know about F18 FDG, where this is radio labeled to glucose. And we don't use this for stress imaging, but we use this to evaluate the myocardium of the heart for several other reasons, and we'll get into it in a moment. Just to kind of give you an idea, if you send an individual for SPECT stress imaging versus PET stress imaging, you get these much, I'd say, crisper, cleaner images. And what are we looking at here? Well, essentially, we're looking at the heart in both short axis and long axis views, and we're recreating an image, specifically the left ventricle, and where we're seeing blood flow and where we maybe don't see as much blood flow. Basically, if you have an area that's thinning or an area that doesn't light up, we're concerned about the artery that's subtending that part of the myocardium. This is an old study, but one I just wanted to briefly mention. This was a study that actually, I think, kind of paved the way for PET stress over SPECT. It looked at sensitivity and specificity between the two, and it actually showed that this was rubidium PET. It showed that rubidium PET actually resulted in lower coronary angiography rates, less false positives, lower revascularization rates, and also actually cut costs down too due to less downstream testing. So when we compare SPECT and PET, we've kind of talked about some of the background of the two differences of them. But one other thing I did want to mention about PET is this whole idea of coronary flow reserve. And this is one of the reasons in cardiology why we really like PET a lot. So let's talk about coronary flow reserve for a moment and what that is. So coronary flow reserve or myocardial flow reserve is the ability to measure coronary flow to the myocardium, which we'll do both at rest and at stress. The idea is if you have a compromise in coronary flow reserve, well, then you're either dealing with some kind of obstructive epicardial coronary disease, the coronary arteries we can see, or potentially even microvascular dysfunction. So let's say their epicardial coronary arteries look normal and they have impaired myocardial flow reserve, well, then you might be dealing with a person who has microvascular disease. And this is referring to disease basically at the capillary level of the coronaries. We say a cutoff of less than 2 is abnormal. And this is just a review article kind of showing how we're able to obtain coronary flow reserve, basically injecting a known volume of tracer into the body and then following it over time and seeing how it passes from the blood pools into the myocardium. And you're left with these really not just nice images, as I said earlier, but these numbers on the right. And you can actually see the relative coronary flow reserve for the different distributions of blood flow of the myocardium that are subtended by these arteries. The arrow sign here is showing that there's basically an abnormality in the part of the myocardium that receives blood from the RCA, which fits nicely with this myocardial flow reserve pattern that's reduced at 1.83. This study, I can't believe it's almost 10 years old now because I remember the study quite well, the Pacific trial. Really nice study that I've really liked a lot. This was a study that compared sensitivity and specificity of various different non-invasive stress testing modalities. And what it demonstrated was that PET actually had a higher sensitivity and specificity compared to SPECT, which I think we kind of knew, as well as coronary CTA for identifying hemodynamically significant stenoses. Now, the one caveat here is I don't think they use CT-FFR in this study, but still very impressive study. But there's been some controversies. The same chest pain guidelines I mentioned earlier gave PET stress for intermediate risk chest pain patients a 1B recommendation. And you can see here, there's all these different societies on these chest pain guidelines. ASNC was not on these guidelines. That's the American Society of Nuclear Medicine. Nuclear radiology, excuse me. And that's kind of, I guess, a whole nother topic in and of itself. But it does have a 1B recommendation for those individuals with stable chest pain and are considered to be at least intermediate risk. Okay, just briefly, what are some other uses of cardiac PET besides cardiac stress PET for evaluating the coronary arteries? Well, we like to look at the myocardium, and it can be really, really helpful to know what's going on in cardiac muscle for those patients, say, with some type of new heart failure. You can look for active granulomatous disease like sarcoid, which we'll talk about in a moment. We can look at myocardial viability. These are people who maybe have a reduced ejection fraction, an obstructive coronary disease and you're trying to understand, is the myocardium, is it infarcted, or is there kind of hibernating, meaning if you were to increase blood flow, say revascularize the individual, are you going to expect an improvement in their ejection fraction? And then kind of an interesting one I think we don't talk about enough is endocarditis evaluation. And mind you, these different imaging modalities all rely on that F18 radio label to glucose. One thing I do want to say about evaluating cardiac sarcoid and endocarditis, if you ever send a patient for cardiac PET, is you have to put them on a special diet. And I'm just going to have to nerd out for a quick second. So a little background, cardiomyocytes create ATP both through metabolism of free fatty acids, so free fatty acid oxidation, as well as glycolysis of glucose. Now, if you just inject FDG into a patient and then you put them in the PET scanner, of course, their myocardium is going to light up because the cardiomyocytes are going to take that FDG and metabolize it. So you have to trick the cardiomyocytes into not wanting to take up glucose. You need to switch their main source of metabolism toward free fatty acid. So what you do is the day before, you put the patient on a high-fat, low-carbohydrate diet, and then you have them fast the night before. Then the morning of the scan, you inject some intravenous heparin. And again, these are all things that you're doing to try to shift that metabolic pathway away from glycolysis and towards free fatty acid oxidation, such that if you have entirely normal myocardium and you inject F18 FDG into the individual, their myocardium shouldn't light up at all. But let's say you have bacteria somewhere in the heart, or you have some type of active granuloma. Well, those are sources that are going to take up glucose, and those are going to light up. Let's talk about PET stress. Now, this is one I have not actually done since I've been here at Providence. So unfortunately, I didn't have any examples of my own, but I did want to go over it briefly. So this is a protocol where I'd say it's reserved for a very specific situation. Let's say you have an individual who has prosthetic material in the heart. Let's say they have a mechanical aortic valve, kind of like our gentleman from earlier. Well, sometimes with echocardiography, we just can't evaluate it very well. So what you do is you put them through that diet we talked about a moment ago. Then the nuclear lab will radio label FDG to leukocytes and then put them through the scanner. And what you'll see here is if there is a bacterial infection of the heart, you'll essentially get something lighting up. And this was an example here, a review article showing a patient who had a mechanical aortic valve with, I think, an aortic root abscess. And actually, if I just go back a slide, the IDSA guidelines have actually given this level 1 recommendation for endocarditis evaluation, especially in these unique scenarios. Here's an example. This was a 48-year-old patient of mine who had presented with new shortness of breath, had a new left bundle branch block, and slightly reduced ejection fraction. And we ultimately ended up sending her for cardiac PET. On the left, we see what's called the raw rotational imaging. So essentially, things that are lighting up would suggest where FDG has been taken up. And what we saw here was there's a lot of perihilar uptake, but there's also kind of patchy uptake in the myocardium as well, all of which was consistent with both myocardial and pulmonary sarcoid. This was a more subtle finding. This was a 63-year-old male, kind of similar presentation, who was also diagnosed with cardiac sarcoid. We can kind of see that patchy uptake here. Okay, and our last maybe 5-6 minutes, poor MRI, didn't give it enough time, but let's kind of go through cardiac MRI really briefly. I think we obviously all know what MRI is. I mean, it's basically taking advantage of the natural spin of hydrogen nuclei, and you use it basically a radio frequency pulsing to the body such that you affect the spin. As the spin relaxes back into its stable state, you can measure those time periods and create imaging of the heart. And this is really nice for us, especially when we're looking at myocardial definition. We use cardiac MRI for a lot of other things too, like shunt studies. We can look for constrictive physiology. I have an example of that in a moment. And then stress testing as well. I'll say I have never actually experienced that of the different places I've worked and trained of using cardiac MRI for evaluating coronary flow. I think that's a little bit more popular in Europe, but there is a use for it. Briefly, I want to talk a little bit about the background of gadolinium before we get into some examples of how cardiac MRI can be helpful. Well, as we all know, gadolinium is our heavy metal that we use as our contrast agent in MRI. And specifically in cardiac MRI, this is our myocardial contrast agent. Gadolinium will accumulate. Well, let me back up and say gadolinium gets taken up by cardiomyocytes. They'll take it up and then they'll spit it out. Okay, so if you inject gadolinium into the body and you immediately scan someone, well, you'll see that the myocardium will light up. It'll look white. But if you wait about 15 minutes, healthy cardiomyocytes should be spitting out the gadolinium. The myocardium should look black, essentially. But if you have an area of scar, like necrotic or fibrotic tissue, essentially just extracellular matrix, well, then you can see accumulation of gadolinium there. And so people in the imaging realm, the cardiac imaging realm, say that gadolinium serves as a marker of essentially extracellular volume. But how that gadolinium basically sits in the myocardium, the patterns of how it sits, we can use to understand specific disease states, certain types of, say, infiltrative cardiomyopathies. A quick word too on gadolinium, and now kind of the most commonly used situation in this scenario, gadavist. I think historically we've been apprehensive about gadolinium and those patients with renal failure due to this kind of risk of nephrogenic systemic sclerosis. Gadavist is an agent that we can use even for those patients with renal failure. The American College of Radiology and National Kidney Foundation have given it an okay, so long as they believe that the imaging and the results of the imaging benefits would outweigh this theoretical lower risk of the nephrogenic systemic fibrosis. Okay, old review article, but really, really helpful. These are the patterns of gadolinium that we look for in the myocardium. So this is late gadolinium enhancement. Again, you inject the gadolinium into the body, then you scan the patient about 15 minutes after, and you look to see where that GAD hangs up. If it hangs up in, say, maybe the subendocardial area or transmurally, oftentimes we think that may be an issue with the coronary arteries or blood flow to the myocardium. Subendocardium is the first part of the myocardium to become ischemic, and so oftentimes, say for a smaller infarct, a smaller end stem or something, that's why you might see that. But now let's say you see GAD hanging up, say, in the mid-myocardium or the epicardium or the entire subendocardium. Well, those become circumstances where you start thinking about these non-ischemic etiologies. And this is actually a patient we took care of this last summer. Elderly patient, history of bilateral carpal tunnel and spinal stenosis, who presented with progressive heart failure symptoms. And on echo, had biventricular failure, and all their chambers were a little dilated. And what you can see here, so this is you can see the ventricles that I've labeled in the atria, but on the right, this is the late gadolinium enhancement imaging we're looking for. And you can see that the entire endocardium is lighting up white. Even in the atria, they're lighting up white. Here's kind of a long axis view of the left ventricle. Again, you can see this rim of subendocardial enhancement. And this was consistent with a patient who had cardiac amyloidosis. Here's actually our first lady that we showed with the PET imaging who had a diagnosis of myocardial sarcoid. Well, she also ended up getting cardiac MRI. And what we can see here is this patchy kind of mid-myocardial uptake across the left ventricle. Again, this kind of fits that granulomatous pattern that we were seeing with her PET, consistent with cardiac sarcoid. This is a gentleman actually I just took care of last week, a 62-year-old male, long-standing poorly controlled diabetes who presented with an NSTEMI, troponin in the 10,000. And we can see basically a transmural infarction in the LAD territory. We can use these cine images sometimes to understand maybe masses that we might see on echocardiography. This initially was a patient who was thought to have a thrombus in their left ventricular apex. However, when they had the cardiac MRI, we actually saw that it was a benign apical lipoma. Here's a gentleman I saw in clinic a couple of years ago. He was a 42, he is, not he was, he is a healthy 42-year-old, healthy, active soccer player, and he ended up getting a screening EKG for a reason I don't remember now, but it was incredibly abnormal. And when we see these really deep, diffuse T-wave inversions, we either think, well, someone's actively having an MI, or we think about the variant of hypertrophic cardiomyopathy, which we call the apical variant. And we send him for MRI, and we saw that his apex of his left ventricle was very thick with LGE hang up as well, consistent with that diagnosis. This was a 48-year-old male who had a history of recurrent pericarditis and was having kind of some heart failure symptoms that we were concerned for constrictive physiology. And so we did this hemodynamic assessment with cardiac MRI, what we call free breathing. And then on the right is tagged lines. That's kind of an older modality now. But the whole idea of using these modalities is we're looking for this concept of what we call respiraphasic interventricular dependence. Essentially, if you have a constricted pericardium, well, the left and right ventricle have to share the space. And between inspiration and expiration, you'll see that septum shift to allow for blood flow, pathognomonic for constrictive physiology. I'm almost done here. This is a 26-year-old male, or sorry, 26-year-old female who came to my clinic who had shortness of breath and an echo with a severely dilated right ventricle. And it's not very well circled here, I apologize, but what we see is a very large secundum atrial septal defect. So an atrial septal defect she was born with blood flow going from the left to the right, leading to right ventricular failure. And she was sent for surgery to have this closed. And this is actually an 81-year-old gentleman I've been following in clinic now for several years who had a prior history of a late RCA STEMI and had the very dreaded, rare but dreaded mechanical complication of a ruptured free wall. Basically, his inferior wall ruptured. But luckily enough, it has been contained by essentially a rind of thrombus and fibrotic tissue. And we can see here on the right, you can kind of see that clot that's formed. Okay, so takeaways. We talked about coronary CTA, highly sensitive, non-invasive assessment for obstructive coronary disease. We talked about how PET over SPECT, offers improved diagnostic accuracy for evaluating coronary arteries. We talked about coronary flow reserve and how it's a non-invasive means to understand myocardial blood flow, as well as to evaluate for microvascular disease. And then I think we also talked about the uses of cardiac MRI as well. Okay, I think I made it with just 5 minutes to spare if there's any questions.
Dr. Layun, indeed you did. Thank you so much for covering a whirlwind of complex cardiac imaging. I'll go ahead and start with one comment and question from our audience here. First off, they say, really enjoying this nerdy talk on different cardiac imaging studies. What can we document in our notes to improve chances of approval by insurance, since they are often stuck in the age-old EKG treadmill test? So any comments on in whom might we be particularly looking that one of these other modalities is indicated? And if so, how to advocate for it?
That's a great question. I think that is a topic that is continuing to change from year to year, depending on how we see, say, private insurance versus Medicare, Medicaid approve certain testing or not approve it. One of the things I've always found useful when I document is, I mean, let's say we're seeing a patient who just recently had hip surgery or something of that nature and can't run on a treadmill. Well, that's a pretty easy way. I mean, you're being incredibly honest, and that's a very easy way to say, hey, this individual can't do an exercise treadmill test. So they're going to need some type of imaging stress testing anyway. might as well do the coronary CTA, for example, if they have, say, no known obstructive coronary artery disease. But that has kind of been a moving target in the past. Sorry, I can't give a more clear explanation. I really kind of approach that on kind of a subject by subject basis.
Yeah, totally understand. A complex topic in and of itself. Here, another question. Thank you for an illuminating talk. Ari, PET. Again, what is the insurance coverage? In Epic, it shows we can order a PET CT cardiac metabolic single, myocardial perfusion, and metabolic or viability. Thoughts on PET coverage and what order?
Yeah, great question. So the one thing, a very important thing I did not say is right now at Providence, we do not offer PET stress testing. So we can order PET for these other things. Say you're looking for hibernating versus infarcted myocardium, looking for granulomatous disease, things of that nature. But we don't have the isotopes, say the fluoropyridaz or the rubidium, um, to be able to do that PET stress imaging now. At PPMC, they're currently working to install their new PET scanner, and at St. V's, I think they put that in last year. And I think as the staff become, trained with the new scanners, there is conversation, and I've been having that with some of the staff there about down the road looking into getting some of these PET isotopes. I think rubidium 82 would probably be the one we would probably go for. But yeah, right now you can't really even order it anyway. So if you do want a person to get a PET stress, I would send that person to OHSU. They are using rubidium PET stress right now, and I think they're going to be getting fluoropyridaz pretty soon.
Great, thanks so much. A couple practical questions regarding ordering and completion of CT angiography. To get the heart rate to goal, any suggestions for a specific protocol or ordering of beta blockers, for example, that the ordering PCP should be doing? And then maybe just secondarily, will the fractional flow reserve be done automatically, or must a second order be placed and have the patient return?
Great questions. So regarding the heart rate, typically if you put in the order, I believe maybe some of the nursing staff from the CT department will oftentimes send a message back to you. And they actually have a protocol and they'll say, we see that in clinic, their heart rate was recorded as such. To try to get their heart rate to so-and-so, please give them, this amount of metoprolol or atenolol the night before and this amount of metoprolol the day of. What we typically try to aim for with the CT scan is a heart rate in the 50s or low 60s, the 50s ideally. But yeah, they should be reaching out to you about that. As for the FFR, my experience has been that this is an order set. And so you can order the FFR with the CT. And what you'll see is if there's a borderline stenosis, the radiologist will then send this to HeartFlow for their FFR analysis, so long as it gets insurance approval.
Great, thank you so much. And perhaps with just our last minute, I'll call out a thank you for the talk from Dr. David Gilbert, also asking, how best to help and coordinate from a primary care perspective. So yeah, curious if questions, perhaps best to call your neighborhood cardiologist, send an e-consult, any last tips for communication on these complex topics coming from the PCPs? Yeah, I think any last tips for care coordination from
honestly,
primary care physicians to
e-consult's
cardiology?
always a great way to reach out, and we're always happy to help coordinate. As I said, some of this has kind of been a moving target, both from the insurance coverage perspective, and also, as I said, like right now, we're actually not doing PET stress. So hopefully, this might be a topic that we may circle back on in a year. That's something we're going to start doing.
Well, that leaves us to the top of the hour, certainly a complex and evolving area. Sounds like we will have you back again someday, Dr. Layun. Thanks so much for presenting.
Thank you very much.